A Sertoli cell tumor is a rare growth that starts in the Sertoli cells, which normally help nurture and support sperm-producing cells inside the testes. Think of Sertoli cells as the caretakers in a tiny factory that makes sperm. When these caretakers turn cancerous, they can form a lump that may make the testicle feel hard or painful. Clinically, the tumor is important because it can change hormone levels, often raising estrogen. And although most are benign, a few can spread and need special treatment. The exact cause is not always clear, but several risk factors are known. Some people inherit genetic changes that predispose them to this tumor, such as mutations seen in Peutz-Jeghers syndrome or Carney complex. Hormonal imbalances, like high estrogen or abnormal luteinizing hormone, can also push Sertoli cells toward tumor growth. Exposure to certain chemicals, for example pesticides or industrial solvents, may increase risk, and people with other testicular tumors sometimes develop Sertoli cell tumors at the same time. Sertoli cell tumors arise from the same cells that normally support sperm, but they acquire genetic errors that make them multiply uncontrollably. Common pathways that go wrong include the PI3K/AKT and MAPK signaling routes, which normally tell cells when to grow or die. The tumor often produces hormones, such as estrogen and inhibin alpha, leading to symptoms like breast tissue growth in men. Growth is usually slow and stays inside the testicle, but aggressive forms can invade nearby tissues or spread through blood vessels. These tumors are very uncommon. They make up less than 1% of all testicular cancers in humans, but they are more frequently reported in dogs and other animals used for research. Most cases are diagnosed in adults aged 30 to 60, although children can be affected, especially when a hereditary syndrome is present. There are no clear geographic hotspots, but reports are slightly higher in regions where genetic testing for related syndromes is routine. Over the past decades, the number of diagnosed cases has risen modestly, likely because of better imaging and awareness. A man with a Sertoli cell tumor may notice a painless lump or swelling in the scrotum, similar to a small bean. Some feel a dull ache that worsens with activity. Because the tumor can make estrogen, men might develop gynecomastia, soft breast tissue, or even experience reduced libido and infertility. In rare cases, children develop early puberty signs, voice change, rapid growth. General feelings of fatigue, mild weight loss, or a just not feeling right feeling can also appear. And a few patients have perineoplastic signs like low blood counts, caused by hormones the tumor releases. First, a doctor will feel the testicle during a physical exam and ask about symptoms. An ultrasound is the go-to imaging test. It shows a solid, usually well-defined mass inside the testicle. MRI or CT can be used to see if the cancer has spread. Blood tests look for hormone changes. High inhibin alpha, estrogen, and standard tumor markers such as AFP or beta-HCG, which are usually normal in this tumor. Definitive diagnosis requires removal of the lump and microscopic examination. Pathologists look for characteristic cell patterns and use stains like calretinin, SMA-WT1, and Ki-67 to confirm the tumor type and gauge how active it is. Staging follows the usual testicular cancer system, describing how large the tumor is and whether it has moved beyond the testis. Pathologists recognize several shapes of Sertoli cell tumors. The classic type has small, tightly packed cells. The large cell variant has bigger, clearer cells. Sclerosing tumors have lots of scar-like tissue, and trabecular tumors grow in thin cords. Some tumors make hormones functional, while others do not, non-functional. Most are benign, but features that suggest malignancy include a size over 5 centimeters, many cells dividing, high mitotic index, and areas of dead tissue, necrosis. The main treatment is surgery. For most men, a radical orchiectomy, Removal of the whole testicle through an incision in the groin cures the disease. In selected small, non-functional tumors, testis-sparing surgery can be attempted to keep hormone production and fertility. Radiation is rarely needed, but may be used if the tumor cannot be fully removed. Chemotherapy is not standard because the tumor usually does not respond well, though aggressive malignant cases may receive drugs such as cisplatin-based regimens. Because the tumor often makes estrogen, doctors may give anti-estrogen medication, for example tamoxifen, to treat gynecomastia or hormone-related symptoms. After treatment, patients are watched with periodic ultrasounds, hormone panels, and clinical exams every 3 to 6 months for the first 2 years, then yearly. Since most cases cannot be prevented, the focus is on lowering risk where possible. People with known genetic syndromes should receive genetic counseling and regular testicular exams starting in adolescence. Avoiding occupational exposure to known endocrine-disrupting chemicals may also help. For families with a history of Sertoli cell tumors, annual ultrasound screening can catch a tumor when it is still tiny and easily removable. Overall, the outlook is excellent for benign tumors. Over 95% of patients are cured after surgery and live normal lives. Malignant tumors have a lower 5-year survival, around 50 to 60%, and depend on size, stage, and how fast the cells are dividing. Important prognostic clues are tumor size greater than 5 centimeters, presence of metastasis, and a high Ki-67 index. Long-term issues can include hormonal imbalance, infertility if the remaining testicle is damaged, and feelings of self-image loss after orchiectomy, which can be helped with counseling and, if needed, hormone replacement. In the last few years, scientists have mapped the DNA changes in Sertoli cell tumors, finding frequent mutations in the PTEN and KRAS genes that activate the PI3K/, AKT, and MAPK pathways. These findings have opened trials of targeted drugs, such as mTOR inhibitors everolimus and MEK inhibitors for patients with advanced disease. New blood tests measuring inhibin alpha and microRNA signatures are being studied as early detection tools. Advanced MRI techniques diffusion, weighted imaging, improve the ability to tell benign from malignant tumors before surgery. Early work on checkpoint inhibitor immunotherapy shows promise, and fertility-preserving options like sperm banking before orchiectomy are now